The main reason that multifocal IOLs, which can be also used for presbyopia, they're highly invasive and they may be suitable for some cataract surgery, but with people that still have a natural lens that accommodates, I think it's a little bit too much to try to use that type of technology. Of course, you can use laser technology by using monovision, or alternatively, you can do multifocal corneal profile. But however, that is a subtractive tissue procedure, but in many cases non-reversible, trying to realign it. And if you have to remove it, if the patient is not comfortable with multifocality. Then we have the corneal inlays. And within those categories, I'll mention later on the kind of products that are available. But I'll focus this evening about the microlens, which I believe is probably the better solution. So initially, the synthetic keratofacial started with Barocare, and he tried in 1964 to implant plexiglass type of implants, but they all failed and ended up in necrosis, and he abandoned that approach. I don't know if you know Vic Lindstrom from the United States. He also attempted to use polysulfone implants. They did not work, but lately he tried hydrogel material, which changed the shape of the cornea. And he told me that they implanted around 8 of those, and he felt that they were successful, but they were not as predictable. And some results were good, some of them they didn't see any effect. So now we come to the 1920s, and there were a few technologies that tried to do that approach with the cornea, so that you can have it reversible without going into ultra. The first product was the camera. It's a pinhole device. Basically, it's a dark disc with multiple micro holes around for allowing infusion of fluids. However, its main effect was the pinhole effect. And unfortunately, when it is dim and dark, patients cannot really see a read if they go to a restaurant. And matter of fact, I can tell you, I was in a restaurant together with another surgeon I was training in Canada. We were implanting our implant, and he asked me to read the menu, and he said to me, "You know why I'm asking you to do it?" I said, "No," I said, "because I have the camera implant and I cannot read." So that was with regard to camera, and the range rope is a procedure that includes under a flap a little bit of hydrogel and trying to change the shape. Unfortunately, with that procedure, it is very superficial, and consequently, you might have some issues with uh, transmission of nutrients, and they really had problem later on, and I'll talk about that. And finally, is the lens I was focusing on is actually an optical lens with high refractive index material with a special optics on it. What happened to camera and raindrop? Raindrop was recalled by the United States FDA. They had actually the product approved, but after a few years, they started having corneal meltdowns and haze, and the FDA forced them to remove it totally out of the market. And also followed later on by camera. They had issue with their implant, especially below the implant, and they decided not to proceed and they withdrew from market voluntarily. So the Flexivue Microlens had the previous version product. It was called the InView. And the idea behind that was that we wanted to have something which is an additive, so you can, if necessary, you can remove it, and with no loss of tissue. And we wanted to develop a material which is biocompatible, and I'll talk about that later. And the product should have allowed metabolism. And the final thing was that you're not really affecting that much the corneal strength by putting it through a small incision and small tunnel in the cornea. In the early days, we didn't have any efficient femtosecond laser. I think when we started at about 30 kilohertz, and the surface was very rough. So we opted to go through a microkeratome, which we developed specifically for this procedure. I don't know if there's a laser beam here, is it? Yeah. So what you see here is a special cartridge I developed, an electronic control unit, which you use very similar to the old microkeratones. You put a suction ring on it, and then it creates a pocket. And we developed a special delivery inserter to pull the lens in. First, we did a lot of biocompatibility studies. First, you got all the bench test studies, which are a whole series of those required by the FDA and the Europeans. But then we started with animal implants. First, we did rabbits. We did 10 rabbits for 6 months. This is the result of the histology, and you see no reaction to the material with rabbits. We followed that with another series of implants with pigs. We did two series of studies, 14 pigs each. Each study lasted about 12 months, and then we did also histology, and we got similar results. That actually information we provide with the FDA is part of the pre-approved to start the study in the United States. So, compatibility of this product is excellent. Now, if it works, this is animation of the old technique. This is just piece of history. The only drawback of this instrument was it was making a lot of noise. So it used to scare the patients. But in essence, the quality of the cut was very good. And I think maybe Professor Polikas can comment that because they had patients that actually gone with that type of procedure and they had the implant for many years. In those days, we used to mark the position where you're going to put the inlay with a 3.2 millimeter ring with marking, and we put the lens within that marking. The implant itself is 3.2 millimeter in diameter and has an edge of 15 microns. We designed the optics to go around, not in the center, because in the center is basically like a pinhole. You don't need to do refraction. You're pretty extended depth of focus in the center. So we did a 1/6 with basically no power, and the rest was on the periphery. And you could select either for 1.5 diopter to 3.5 instead of a quarter of a diopter. And we also provided a nutrients hole in the product. What I would like to comment about that nutrients hole and actually the depth of implantation was the fact that we did studies at the University of Bern to see how we can simulate flow of nutrients through the cornea without affecting the anterior surface. And we found that even without the hole, if you implanted around 250 to 300 microns, the flow around the lens is sufficient to reach the surface. We, for safety, added a hole in the middle, so now you have the flow around the lens and in the center to provide you with the necessary flow of nutrients. And now, obviously, I know that ICL, which also I designed, we did the hole there as well to provide nutrients and circulation of fluids within the eye. So the principle of operation, most of you probably already are aware of it, but in essence, if you implant it and you look at the near objects, the center is basically like a pinhole, and they obviously have a very large depth of focus and it focuses itself onto the retina. And then when you add the rays coming from near again into the surface of the add-on part, and then they're refracted onto the retina, they all get focused. At that point, also, when you do reading, you have sufficient lights, and the pupil is usually smaller, as around 3 millimeters, and that will give you pretty good visual acuity for near. At far distance, the pupil is usually a little bit wider, and again, the center for the far vision rays, they'll focus automatically onto the retina for hematropes, of course, or if you don't have an hematropy, you make the patient hematropic and you'll get it focused. And however, the drawback of this approach is that the rays that go into the lens itself or the added part, they'll get a little bit ahead of the retina, and you're going to get some defocusing around that area and create a little bit of a blip. And finally, you're getting the rays that go outside and they'll focus onto the retina. The brain then tries to switch between those two images because they have more energy. With the blue ones, it will prefer that one and it will probably focus on that. That's why we require a few months of neuroadaptation to allow the patient to see better with the operated eye. Now be aware this procedure is done on non-dominant eye, only done in one eye. We did some simulation. I won't go into much detail that shows what happens for distance vision and the simulation. It looks like with the implant, you're still getting pretty good images. And we're showing here for the people that are presbyopia and don't see very well near with the simulation. However, with this added lens in the cornea, they'll get pretty good image at the approximately 3 millimeter diameter when the patient does reading, and the brain can process that image, and you can get a satisfactory result. Here we can see the original tunnel that we did, or the pocket we did with the microkeratome, and we decided to duplicate that here with the laser. This is the laser one, and this is with the microkeratome, and this is the results. And we started doing some studies in Latin America and in Greece and in Italy. So this is actually a video courtesy of Professor Palikwe, some of the cases we did. And that will give you the idea. We use a LASIK procedure on the femtosecond and put a mask to block the rays, so it only opened at a limited area here rather than cutting the whole flap and having the hinge here. So after delivering the lens, you're basically centering. Some of you already done the procedure. This is actually blinking light if you'd like to center around the lens, and then basically the procedure is done. The early work we did at preclinicals in Mexico, we just wanted to see how well it will work. We did initial patients around 2003, 2004. We waited, and now we did a series of patients, and we certainly can demonstrate that the uncorrected near visual acuity improved from this area to that significantly, and also the binocular one, you really don't lose anything, and you can gain near vision. The main study that we did was in the United States. It's 421 patients, a prospective study. Was at 11 centers. The age group was between 40 to 60, and it lasted 36 months. So 3 years follow-up. Implants were done between 280 to 300 micron using femtosecond laser and our masks, as I showed earlier. You can see here the result with OCT, the 300 here micron depth, that's the lens. It's probably a larger diopter lens. You see here the add-on power. This is usually flat, and that's the image. The edge is here, and the total implant shown here. So those OCT actually images, I think, came from Marco, right? If you remember those, we did before surgery, and then 1 day, 1 week, and so forth. Basically, after about 1 month, everything is normal, and 3 months, it is basically back to normal. And of course, the first day post-op, you won't be a meaningful result because the swollen cornea. And the wavefront analysis, you can see here that what I call the donut effect, you get an add-on power, which if you subtract this is before it's after surgery, then you'll see actually the myopic effect on the brain, the resultant of this procedure. We did with tracy analysis of the through focus, and you see here quite clearly one peak and very small depth of focus is 0.089, I think. I cannot see it from this angle. It's pretty narrow for the patient has presbyopia. Now, if we look after 2 years, you'll see 2 peaks, one for the distance, one for the near, and a little bit of a saddle here, which gives you the intermediate, and then gives you now depth of focus of a 4 diopter, which is basically good for general life and visual acuity across a big range of distances. Those are the results, the uncorrected uncorrected near visual acuity improved by 5 lines of the FDA study. I think the studies we did in Europe and South America on average was 6 lines because the patients that were enrolled, they were actually even worse off than the one that were enrolled in United States preoperatively. So when they improved, they had actually 6 lines improvement. But as far as the uncorrected distance visual acuity, you lose about 2 lines. This is in logma. And you can see here the trend that after about 3 months is basically stabilizes here and here. But within a week, there's dramatic improvement. As far as binocular, you can see far and near, no problem, because this is a procedure designed to work with both eyes. So you have the dominant eye, which is left hemitropic, and then you have the add-on on the non-dominant eye. So you would expect to get pretty good results. So the patient with 2 eyes can see very well distance and they can read very well. And we got a bonus with that subtle effect I showed you with through focus that the intermediate also is gaining about 2 lines. So that's also a nice bonus for this procedure. The best corrected, we are losing about 1 line in distance and we're not changing. There's no significant difference with best corrected near vision. So the near vision is actually an excellent outcome. Part of the study required patient feedback and analysis, and in essence, I think that the message here is about over 92%, almost 93%, were very happy with the results. Poor only suggested it was 1.6. And with regard to wearing glasses, there's always only 2.7% wore glasses all the time, but almost 78% never use glasses either for far or near. And we asked them what happens if we want to do this procedure again, would they do it? And about 91.3% says that they will recommend to do it again for themselves or their friends. We still had 8.7% were not happy, and we suspect most of those were those patients could neuroadapt, and some of them actually had to explain, not because the product did not perform, it's just that they could not adapt to this multifocality. This is a nice little piece of a video that came with courtesy of Sami from Kuwait. We decided to use the Zimmer 8, and this is kind of done it about, I think, 2 months ago in Kuwait, and you could see that the Zimmer does it. We don't need any masks. Gives you a quite nice cut, and this is the procedure using the actually inserter itself, which picks up the lens. But you need here to use a cannula to hold it, and finally you're centering in the visual axis.